It is my great pleasure to introduce a colleague and a friend, Dr. Steve Jenkusky. Dr. Jenkusky is a graduate of our residency program. He then went on to lead a number of clinical and administrative teams in our department, and more recently in the Presbyterian system. He's currently the medical director of Centennial Behavioral Care at Presbyterian Health Services. And prior to that, he was the vice president and medical director of at Magellan Healthcare and the chief medical officer for the behavioral health program at Presbyterian Health Plan. I first met Steve when he was on faculty in our department in the Roadrunner room. We supervised residents in the general clinic. And in between cases, I got to hear about his past lives in New York, in Maine, and as a wildlife biologist and a father. Relevant to today, Dr. Jenkusky has served on the New Mexico Medical Board since 2009. He was the chair for 5 years, and for the last 3 years has been the medical director. He has a privileged perspective on the role of medical boards in protecting the public and in holding physicians accountable to our norms and values. And this is really fundamentally important if we are to retain our independence as a profession. We all hope that we never come to the attention of the medical board, but it's good to know how it works, and that's what Dr. Jenkusky is going to present to us today. So please join me in welcoming Dr. Jenkusky back to UNM.
Great, thank you, Jonathan. Let me get my screen going here. What is it doing? I'm getting some security message here. Share screen. Do I need permission from you all to share my screen, or?
No, you should be able to share your screen right now.
Okay. It's asking for a security permission. Oh, maybe that's it. Maybe that's what I need to do. Let's try that again. Share. Oh, sorry. I don't know why it's doing this.
Would it work to send it to Robin or to me and we could load it? Or?
Yeah, I can share it if you need me to.
Can you do that? Okay. Yeah, it's asking me for security, but then I'm not sure why I'm clicking on Cisco. Oh, Zoom. Maybe that's what I need to do. Click on lock to make changes. Press there. I think I might have done it. Let's see. All right, I'm going to do some more time. If this doesn't work, I'm sending it to you guys.
Okay, and if it's the same one you sent me, I can just load that up.
Can you do that? That would be great.
Yeah, that would be great. Thank you so much.
Great. All right, Jonathan, great. All right, let me get started while Jonathan's doing that. Yeah, he said exactly, would be my first comment is that, hopefully the medical board is an agency that's just in the background that you have to interact with maybe every 3 years to renew your license, check off some boxes, send in some money, and you're good. Every now and then the medical board does intrude on practice, although we really try not to, usually driven by some either crisis event or the state passing a statute. For example, the opioid crisis. The state compelled us to get involved in physicians' practices in a more intrusive way because of the concerns around that. But generally, the medical board and I'll say this a few times, applies sort of guardrails to practice. We should be a self-regulating profession. We follow standards, that we develop internally, through research, practice, etc. But that's the hope. Having said that, there are, docs that, wander off the trail from time to time. We try to bring them back in, and while we're protecting the public, we also try to help docs stay in practice. And there we go. So, Jonathan, will you need to drive?
Do you want to try and drive and see if that works? And if not, I will.
Let's see. I don't see a way of changing, so I might have to have you go next slide.
Okay, just ready? Okay.
Ready. Yep. So the objectives of the talk today, I'm hoping it won't be too tedious. I'll try to jazz it up a little bit. Let you know how the medical board works. Let you know how we assess docs with ethical or unprofessional challenges. Give you an idea of how we go about investigating and dealing with disciplinary issues. And then at the end, hopefully, if there's time, I might go on a little bit about some of the challenges we've had during the pandemic, during the COVID crisis, especially with misinformation, disinformation, a lot of the controversial stuff that's gone on in the practice of medicine during that period. Okay, next slide. So the medical board operates under these 6 statutes. So basically, statutes are laws, and then we promulgate regulations that take care of the nitty-gritty. But the Medical Practice Act is our primary act. There's an Impaired Healthcare Provider Act that guides how we work with providers that have addiction, mental health, or physical problems that can cause impairment in their practice. The Pain Relief Act that was passed about 20 years ago, which that's worthy of another talk someday, initially was passed to promote the treatment of pain using opiates. It has been amended over time to go in a different direction. The Naturopathic Act, I don't know how many of you know what a naturopath is out there, but they do a kind of, I don't want to use the massage therapy, but they work with the tissues, soft tissues. They consider themselves the soft tissue analog to chiropractors that do bony joints and stuff. And they've been with the board since 2006. There's a Uniform Licensing Act that affects everybody licensed by the state. And very recently, 2 years ago, the naturopaths joined us. And the thing I was joking about earlier is right now in the legislature, there's some talk of the prescribing psychologists joining the medical board, which I am advocating for because I think we'll do a better job of regulating them than the psychologists themselves would. So next slide, Jonathan. So the functions of the board broadly is to license healthcare providers assigned to us by the state, to verify qualifications, do first source verification of documents that you really graduated where you said you graduated from. We assess minimum requirements to practice, and this is important. We do not proactively determine competency. If you've got all your ducks in a row, you board certified, you did, practice here, we do not look at competence unless something alerts us. So, for example, if one has not practiced for 2 years, we may, or more, say you've had a baby, or, you had to, take care of a sick family member or something like that, we may require you to jump through some hoops to show that you can still practice safely in your specialty. In the lower corner, we attempt to establish proper ethical and moral standing of applicants and licensees. And this is it. I'll talk about this more later. This is interesting. Not all states have a moral requirement. You can be as moral as you want as long as you're not getting into trouble practicing medicine. And Texas turns out to be one of those states, which we've had challenges with that because we'd have we had licensees come from another state that had some pretty shady interactions with the law and others, but it hadn't affected the medical practice. And we scrutinize those applicants. We support continuing medical education, of course. We've done a lot on the pain management over the past few years. And then finally, a part of our mission is to aid in the rehabilitation of impaired providers. All right, Jonathan. So we're structured, the board members are appointed by the governor, but the statute requires that the medical society provide the governor with a list of 5 candidates. And it's a 4-year term. And there are non-physicians that are appointed directly by the governor. I was appointed in 2009 by Governor Richardson, if everybody remembers him, and then amazingly was reappointed a couple times by Susana Martinez. And my term actually was up in December, and I'm not looking to be reappointed. I'm going to do something else for the board. But you keep showing up until the governor tells you to either stop showing up or you get replaced. So you can have a time that goes more than, we've had some people stay on for quite a bit longer than their 4 years. The board formally meets 8 times a year. We do other work in between. We have a staff of 16, and we are a freestanding independent agency that's supported by your fees. We are not supported by taxes, and we're not part of RLD, which is a big mega group that licenses a lot of other groups. It's very helpful that we are our own group because our staff knows what they're doing. And it includes, as it says here, licensing experts. We have our own investigative team, compliance publication officers, and we have our own prosecutor. We have a lawyer that prosecutes our cases. Next. These are the current members. Just to show you the specialties that are on the board. Karen Carson is a pediatrician. Dr. Anderson is a urologist. I'm a psychiatrist. Dr. Bodette is an ophthalmologist. Eileen Barrett is internal medicine. Dr. Unversat is internal medicine. Bradley Scoggins is family practice. Christine Reddy is an ophthalmologist. Kathy Johnson is a PA. We have 1 PA. And then we have 2 public members. 1 is vacant. So someone who is non-medical is on the board. You can see it's a nice array of specialties. One thing that I hope the governor's office will consider, the first psychiatrist on the board was Dr. John Lauriello. And some of you may remember him. He was a prominent professor. He went on to be chair of the department in Missouri. But he was appointed, served for maybe a couple of years, and then when he left, the board really saw the benefit of having a psychiatrist because of these impairment issues and behavioral issues that we sometimes encounter. Okay, next, Jonathan. So this is who we regulate. There's a variety of types of licenses. What's interesting is we did merge with the osteopaths about 2 years ago. That's worked out very well. They were given 2 positions on the board itself. But we also license physician assistants, the naprapathy and naturopathy docs, anesthesiology assistants, genetic counselors, and polysomnographic technologists and trainees. Okay, next. So talked already a little bit about how we vet credentials. We do background checks, and everyone gets fingerprinted. So every now and then someone gets a little bit of trouble because they forgot they got arrested, a long time ago or before they became a physician, and they may not have been charged with anything, but that pops up. So it's important to just, if you're applying for any application, any state, just tell them everything, and then they'll figure it out. It's better than being found to have not been complete. We then, the way we build our guardrails is we don't go out looking to investigate folks. We rely on complaints that come in from outside entities. And that includes, there's something called an FBI wrap back program that if someone gets arrested or gets in trouble with the law, we hear about it if they have a license. We will assess issues around impairment. I'll talk about how we do that later. And we do this to ensure that licensees are practicing safely, competently, and ethically. Okay, next slide, Jonathan. Complaints. Again, we don't go on witch hunts, as they say. We rely on complaints that come in from patients, families, colleagues, pharmacists, employers, insurance companies, the DEA, and board generated. One thing about the DEA, unless it's a huge case, it looks like a felony case or whatever, the DEA, when they find something that they're concerned about, they usually turn it over to us. And we work on the civil side. We don't work on the criminal side. The complaints, and I don't know if any of you have ever had a complaint issue. At first, it's a little scary, but we review it to see that it really applies to the Medical Practice Act. Is it relevant? Is it frivolous? And if it looks like it's appropriate, we investigate. We get a fair number of complaints these days that we don't act on that are really service complaints. That's a term I learned working for the insurance company, where someone didn't like the way they were treated by the front desk, or they thought, they had to wait too long in the waiting room. Believe it or not, we will get complaints like that. And we don't, those are not considered to be relevant to the Medical Practice Act. When there is an investigation that's done, we're going to move forward, that goes to our investigative team. They put together the information and they bring it to a subcommittee of 2 board members who see all the material and make a decision as to whether, what the board as a whole should do. Because if it goes to the whole board, the case gets de-identified. They remove the doctor's name and location and the board as a whole then says, okay, let's do this about this case. And the first thing is the vast majority of cases are actually dismissed, or if they're not entirely dismissed, they're dismissed with an advisory letter. So we'll send a letter saying, don't, you did this, don't do that again. It's not reported. It's all kept confidential. And, we keep track of those letters, but once they, the case is closed in those cases.
Steve, I can't. There
we go. I'm back. I know I just winked out for a second. All right, Jonathan, next slide. So if we decide to take action, we state what the violation was, and we have to quote from the act, like conduct unbecoming or gross negligence, whatever. You'll see the list of things. Very rarely, if we feel that the public will be put immediately at harm, we can order the suspension of the license. That happens very rarely, maybe once or twice a year, that we think that someone is, grossly impaired or they're doing something really dangerous. We can, right in the moment, suspend their license. We're very careful about doing that. We have to be prepared to go to a hearing within 2 weeks if we're going to do that. So we have to have our ducks in a row be ready to make our case. The board prosecutor, we will direct the prosecutor to first talk with the licensee and try to negotiate a resolution, not unlike a plea deal, because very often they will say, okay, I see I did this, I will do this. And I'll talk about some of the things we ask people to do to rectify the situation. If the doc refuses, we issue something called a notice of contemplative action. That's kind of like an indictment, on the criminal side. And if there isn't if they really want to fight it, it goes to a board hearing. It's kind of like a a judicial hearing, except the full rules of evidence aren't in place. And for those of you that have testified in mental health court, it's the same level of evidence. It's preponderance of the evidence, not, beyond a reasonable doubt. So it's kind of like it is a civil action. From either as part of a settlement or part of the outcome of a hearing, we can go do a reprimand, which is basically a letter saying we reprimand you for doing this. That goes into the National Practitioners Data Bank. It's reportable and it's on our website forever. We can also issue fines. We can stipulate remediation, saying we want you to go to addiction treatment, or we want you to take an ethics course. I'll talk about the ethics course in a little bit. We may want you to go see someone like Dr. Bolton, who could tell us what your problem is, and see where we go from there. So we've got a number of tools in the box here. Very rarely we will ask the individual to give up their license or permanently revoke the license. And we've had an example of this is we've had a couple of providers in the past who were doing such a terrible job in their practice that we sent them for a competency eval, and they were elderly, and the evaluating agency said that they needed to repeat their residency, that they were that far gone. And in those cases, that's impractical. So we had to revoke the license permanently. It's very rare. You'll see the numbers towards the end of how often we do that. We really do try to remediate the situation. Oops. Did it jump ahead?
I just moved it ahead. Was that too soon?
No, that was good.
Okay.
That was good.
Okay.
So now don't be frightened by these slides. There's going to be a lot of words, mostly because I was putting them in context of the actual statute to help you understand how we look at ethical, unprofessional, or there's an old-fashioned term, because I think the original act was from the 70s, of dishonorable conduct on the part of the physician. So this just shows from a statute, that we have the right to either refuse the license, because sometimes it's someone who's applying to us for a license. When we look it over, we go, no, there's issues here. So we may actually decline to license somebody. The standard for that isn't quite as high as taking someone's license. That's viewed in a different way legally when you take something away rather than declining to give it. But we have found, over the years, 13 years, whatever I've been on the board, every now and then some high-powered New York City doc suddenly wants to work in a rural hospital in New Mexico. They've suddenly found some altruistic fiber in their being, and they want to come help do colonoscopies in Ruidoso or something. And we scrutinize those, because it's not unusual to find that this is someone who got in a lot of trouble. They either had some horrible malpractice case, or they were beaten up by the New York medical board, and we will scrutinize them closely. I'm not saying we wouldn't give them a license, but we certainly would scrutinize those. So this shows in red that it's in the statute that not only should the licensee be competent, but of good moral character. And that's, maybe not entirely clear what that means, but it is something that we do look at. If there's someone that has had, a significant history of, like domestic violence or something like that in their private life, we may ask for a psychiatric evaluation or something, before giving them a license, if we decide to give them a license. Okay, Jonathan, next. So this, again, don't be afraid. There's going to be a lot of words here, but I'm use this to kind of go through a litany of what are considered ethical or dishonorable issues. And the first one is, it's curious. That's just like there used to be an anti-abortion clause in the New Mexico Constitution, which was removed I think last year or the year before. The very first thing was procuring, aiding, or abetting a criminal abortion. Now, fortunately, we've got the word criminal in there because now it's really not applicable. Employing someone to solicit patients for licensee. That I'm not sure what that is exactly. If you got someone out on the street saying, "Come on in, and we'll give you a Xanax prescription," but that's number two. Number three, and this could happen, someone who is being kind of a shyster, saying they've got a cure that's not legitimate, representing to treat an incurable condition. Next is fraud. 5 is basically HIPAA violations that preceded HIPAA. 6 is if someone is convicted of, essentially, if you're convicted of a felony, you could potentially lose your license, or misdemeanor if it's related to the practice of medicine. So if you commit a crime around the practice of medicine, so say, you do Medicare fraud or something like that, that can put your license in jeopardy, which kind of makes sense. 7, habitual or excessive use of intoxicants or drugs. So basically, showing up at work intoxicated. 8, that fraud is mentioned again, but this is for applying for a license. And that occasionally occurs. We will have someone, most of the time it's innocent and it's fine. You left something off, but occasionally someone, kind of like the New York representative, will flat out lie in their application, and that's not a good thing to do. Then the last one is making false statements. That's similar. Here, impersonating a license or practicing as a license under a false or assumed name. About 10 years ago, we did find a doc who had lost his license in North Carolina and was working in a psychiatric practice in town. And that actually, if you practice medicine without a license, it crosses over as a felony. It's not just civil. We hand those over to the AG to prosecute. Gross negligence and manifest incapacity or incompetence to practice are on there. One thing about pursuing incompetence, very often we have to use an expert. So when it's something sort of ethical, we can kind of figure out what's going on. But if it's something where someone is, and this happens mostly with pain cases, injudicious or excessive prescribing of opiates, we'll use an expert, like a pain expert, to come in and say, yeah, this is outside the standard of care. 14, we can base discipline on discipline in another state, which this is upsetting to some folks, but what it allows us to do is to not necessarily have to re-adjudicate something that happened in another state. Like if California pulled someone's license, we can look at that and we don't have to bring in all the witnesses and demonstrate what was demonstrated in the California hearing. We can rely on what was done in that state to make a decision about whether we want to have this individual work in our state, or do they have to do some kind of remediation. Again, more fraudulent, fee splitting, prescribing a controlled substance, basically, for other than a therapeutic purpose, conduct likely to deceive, defraud, or harm the public. We actually use that one quite a bit. And we often add repeated similar negligent acts, when someone has done something, repeatedly. Okay. Abusive billing practices. And then just 21 just shows the number of ways that you, or a number of times that you really need to let the board know. Like if you, I'm on a peer review, I work with a peer review committee with the Press Health Plan, and on rare occasions, we will do a quality case where the recommendation is to essentially kick that person off the plan. And something like that, the individual is supposed to report that to the board. something that involves serious quality issues. Or engagement law. If you get arrested for a DUI, you're supposed to tell us that. That's something that often gets missed. There's a 30-day reporting period. Okay, Jonathan, next. Yeah, failure to report. That's similar to the one we just did. Abandonment of patients. That gets a little tricky sometimes, and you'll see further down. We also incorporate the AMA's Code of Ethics. We refer to it. We actually cite it in our regs as something we follow, and they talk about abandonment of patients. Basically that you just didn't disappear. That you made some effort. You can discharge a patient, but it shows that you made effort to do an orderly transfer of care to help them find another provider. Injudicious prescribing. That's a big one, and we've done. That's gotten a little better, but during the opioid period over the past since probably 2012 or so, when we've really been focusing on injudicious prescribing because of the opioid epidemic, we've done a number of those cases. There was again, this worthy of another conversation another time, but and you all maybe if you're old enough know this, that there was a push maybe 25 years ago to increase the use of opiates and to start using opiates for non-cancer pain and chronic pain. And a lot of the drug companies were complicit in pushing that. And so that there were a lot of docs that, back then felt that you could just give someone as much opiates as they needed, until their pain went away. Turns out the pain never goes away. So that we had to kind of move the boat, turn the ship on that one. Conduct unbecoming, that's kind of a catch-all, but it's one of those things where you kind of know it when you see it. But we add that on. It's kind of been a unfashioned term. The very last one, 30, is that you can't get out of not telling us something's going on by quitting while you're under investigation. So that's something that, if there's an investigation or disciplinary action pending in another state and you just drop your license, you come to New Mexico or you have a New Mexico license, we want to hear about that. So you can't get off the hook. One of the issues the board has been dealing with for the past few years, and we haven't quite wrapped our arms around that, is there's a lot of doctors work for a company or work for a locum tenens group or something like that. And in lieu, if their quality is a problem, in lieu of their being let go for the quality reason, which is reportable, they'll just fire them or without cause, with the feeling that they don't then have to report that. So we're finding some docs with quality challenges, and not just incompetence of practice, but behavioral problems, disruptive behavior, things like that, they kind of get around that being documented. And so we haven't quite figured that one out yet, but it's like, instead of being handled by within the medical staff, it's handled by HR, and they're let go. All right, Jonathan, next. All right, some very straightforward ones. You shouldn't have sex with your patients. You should maintain good records. The undertreatment of pain, again, that's an old one, but that's in there. Interaction number 36. This is where behavioral issues are accounted for. Someone with disruptive behavior, it's thought that adversely impacts the ability to render care to a patient because of their it affects the whole team. Then divulging privileged information, again, HIPAA stuff. And this last one, the use of conversion therapy on a minor, that's the newest addition to this list. And that was from a law that was passed maybe 10 years ago that made it, and you all know what conversion therapy is. It's trying to help a gay person change their orientation. That was made a crime, and this is where, and I'm happy to to say this, but that came up under Governor Susana Martinez administration, a Republican, and someone from her staff actually called me on the board and said, "What do you think about this? Do you think the governor should sign this?" You know, and I'm not political at all. She just called the board, and the board said, "Well, we have a psychiatrist who knows what that is," and so I was able to advise her. And they not that I made a big difference, but I think it was helpful. The current legislature has a bill to make conversion therapy for any age illegal. So that's something that's floating through the legislature right now. Okay, next. So yeah, I'm not going to bore you too much with this. This has applicability mostly to telemedicine. It basically says that to have a patient-physician relationship, you should have an interactive encounter, which means you're communicating back and forth, you know, either in person, visually, you're collecting appropriate information and generating a medical record. One of the challenges, I'll talk about this a little bit at the end, is telemedicine has exploded. And there's some good things happening with telemedicine, and there's some squirrely things happening. So, for example, if you wanted some Viagra, you know, you could go in on an internet site and answer a few questions, and they'll ship you some Viagra. That's illegal in New Mexico. It's not necessarily illegal in every state, you know, because that's not an interactive encounter. So we're trying to revise our telemedicine regs to accommodate all the growth. You know, there's teledermatology, there's all kinds of stuff that it's turning out to be a big headache. But anyway, this is what our regs currently showed, and it's under ethics. This is before my time, but this was under ethics. We don't have a specific section on telemedicine. Okay, next. All right, we can skip this one. I'm getting redundant there. And I'm just putting this one in here to show that this is where we say we rely on the Code of Medical Ethics and current opinions with annotations of the Council on Ethical and Judicial Affairs of the American Medical Association. Next slide, Jonathan. The AMA, this isn't meant to be read. This is just to show that, and I'm sure most of you know this, that the AMA has a code of ethics. So we incorporate that code of ethics into our regulations by reference. And it includes things like patient abandonment, consent, maintaining records, and things like that. Next slide. One AMA ethic that comes up fairly often is treating yourself and your family. And this is what we rely on for that. And it basically says that in general, physicians should not be treating themselves or family members, mostly because it's not it's a dual relationship. You know, the family member may not be comfortable saying no, or vice versa. You know, so the AMA thinks it's not a good idea, but there are exceptions, and we're okay with that. In an emergency setting, absolutely, you know, provide care. And very importantly, for short-term minor problems. So, you know, if you're, you know, the famous probably one is a Z-Pack. If you remember a Z-Pack, zithromycin or whatever, I think it is, you know, ordering an antibiotic or, you know, something that you should avoid doing controlled substances, but, you know, like a one-time thing, or if you know how to suturing up a small cut, that kinds of things are okay. So then it goes on to talk about a little bit about why it's not a good idea to treat, but it's basically okay. Docs get in trouble, and we find it every now and then where they are just doing month after month prescribing. One thing we've had docs get in trouble for prescribing for, say, girlfriends. You know, it hasn't happened with boyfriends ever, but girlfriends, and then they break up, and then the girlfriend rats him out that he's been giving me Xanax or something, and then he's in trouble on multiple levels. So you just want to be careful in treating family or yourself. And pharmacists will report you too. They will sometimes drop a line to us, drop a dime, drop a line. Okay, next. Doing pretty good on time. So again, this is repetitive. We get a complaint. We do not go out looking. The only thing we've done in the time that I've been on the board, and I think it was driven by the intense scrutiny of prescribing opiates, is that the PMP was made mandatory. Consulting the PMP was mandatory for controlled substances if you did more than a 4-day supply. And the Department of Health was pointing out, or the Board of Pharmacy, that the compliance rate was miserable, like 20% or something. So we actually started looking at compliance, and we haven't really prosecuted anybody, but we were sending out letters and saying, hey, we noticed you're not using the PMP. But that's as far as just investigating unilaterally practice. Otherwise, we get a complaint, we can subpoena records, we will interview involved individuals, we will ask the doc for a response, like what was going on here. Again, it's presented to a committee member that sees the whole file. They do not vote, though. They recluse themselves, and the rest of the board votes based on what's presented to them. And again, it's anonymous what's presented. Board votes on a disposition and then goes on to apply discipline. Okay, next. So how do we evaluate unethical behavior? Basically, we have to confirm the events happen, and if it fits one of those items that's in the list, that extensive list I showed you, then that meets the definition of unethical behavior. Sometimes that's not so clear. We might have to do a deeper investigation, and when that happens, we may request of the individual a competency eval, psychiatric eval, substance use assessment, neuropsych, or Dr. Bolton has done this for us in the past, professional evaluation. So we'll get some folks would say behavioral issues, doesn't really seem to meet the criteria for having a psychiatric disorder or personality disorder, no abuse issues. We'll ask for a professional evaluation, and we'll be able to hear back, what was found and recommendations. If we're uncertain, we can do something called an IPC, which is an impaired provider committee, where one of the statutes, the impaired provider statute, allows us to ask any licensee to come in and talk to 3 providers. And it's usually a psychiatrist, could be someone else of any specialty, and then somebody of the same specialty of the individual being interviewed. And I've done a few of these. I've been on those committees. Basically talk for an hour. It's not a formal psych eval, but you just do kind of an eye-to-eye assessment of the individual and see how they talk and see how they behave. And then from there, we can go, and we've interviewed people that have come in and presented pretty well, but just some things weren't clicking. And then we said, you need a deeper eval, sent them for a neuropsych eval, and discovered that they had frontal lobe impairment. It's an interesting process. But the impaired provider committee, it's voluntary. You can get CMEs for it. I don't know if anybody recognizes them outside the state, but it is a tool that we have. So now, what are our options? Again, we really want to see remediation, and to enforce remediation, we actually put a stipulation on the license. So you get a license that says you are licensed to practice, as long as you are getting this kind of treatment or doing these CMEs or whatever. We also, as part of that, can say we have to monitor your practice. We want you to do certain CME programs. And I think the next slide, Jonathan, will give an example of one of the tools. So one of the tools that we have is a program called CPEP that is in Colorado. It's the Center for Personalized Education. They're not part of us at all. It's just one of the places we send people. And they have a number of programs. This is one of the places we send folks when we wonder if they have clinical competency issues. And you can do it by whatever now. They used to have to go up there. But if you're a family practice doc, for example, they will have simulated cases. They'll look at your records. They'll have you interviewed by family practice docs, and they will come back and give us recommendations as to whether you're good to go or you need remediation or forget about it. There's a medical record keeping seminar. There are still lots of docs out there that write indecipherable notes by hand or have got awful electronic medical record systems. And so we will sometimes have them do that seminar. For folks that are perhaps having challenges communicating with their patients or their colleagues, there's 2 courses there, one on patient communication and one on interprofessional communication. There's a prescribed controlled drugs course to help people spiff up their prescribing. We're very careful about cutting off folks that are doing injudicious prescribing unless it's really, really unethical or awful, or they've got like a pill mill going. Because what happens when you pull the license on someone who is prescribing controlled substances? Where do those patients go? You know, they show up in the emergency room or whatever. So we try really hard to do and get them back on track before anything, bad happens. Yeah, PES, someone just put in there, right? I've been there too. So, and then the last one is very interesting. See what you think of this. It's a probe program. And Jonathan, the next slide will describe what the program. This is where we send folks with ethical and boundary issues. And, you wonder, how do you do that? How do you teach someone ethics? Jonathan could probably expound on that, whether that's even possible. But this is what we use. And it's a program that, like it says here, targets the participants' professional misconduct. And it's 16 hours long. They have pre and post assignments. They attend group sessions. And it's usually hosted by, there's all kinds of people that do it, but a couple that we've gotten back in the past, it was a philosopher and a psychologist who ran the course. And you could be any kind of specialty and be sent into this course. And one of the things that you have to demonstrate is you understand what you did wrong, bottom line. And to pass the course, you have to write a final essay that identifies, why did I get in trouble with the board? And why is this an issue? And they have to be able to talk about, ethical concepts, and all this is, they're given scenarios and stuff to try to learn this. So I think if again, I don't know that you can really teach someone to be ethical, but like talked about with a lot of narcissists and antisocials, if they're smart enough, they'll know how to fake it. And maybe that'll keep them out of trouble. But this is the one tool that we rely on a lot when we've got folks with ethical difficulties. Next slide, Jonathan. There's one more slide on this topic. Examples of when we send folks there, it's for boundary violations, privacy and respect violations, misrepresentation, lying, billing irregularities, disruptive behavior, failure to do informed consent, misuse of social media or electronic medical records, and failure to supervise. Okay, next. There's 3, you either unconditionally pass, which means the faculty feel you got it. And we see the essays. The essays come down to us, and we use that to decide if the person is kind of off the hook or we have to do some more work. Conditional pass, where they kind of got it, and then fail. Interestingly, the folks we've seen with conditional pass are often folks with English as a second language. And it's not necessarily that they didn't get it. It's just that maybe they weren't as good as in writing English, essays. But most people get it. We've had very few, maybe 2 or 3 failures in the past. And usually there's probably a personality disorder buried in there. All right, next. So this, don't glaze over too much here. This just shows that we've got 8,000 licensees, and this is how many get in trouble. So it's not each year. So it's not a tremendous number. On here, of course, I'm pointing at it, which you can't see what I'm doing. But for fiscal year 22 stipulations, 23, that means of those 8,000, we are requiring 23 to do some kind of remediation to be able to continue practicing. Summary suspensions in the middle, 5. It was kind of a big year, but usually, like I said, it's usually a couple. Hearings, there's 3. One of the things that's happened over the 13 years I've been on the board, when I first started on the board, doctors rarely engaged lawyers to fight discipline. They would come to the board, we'd work things out. Sometimes board members served as hearing officers. I served as a hearing officer several times, listening to the case and, asking questions and stuff. That has changed tremendously. Almost always docs are now hiring lawyers, and we are having to use professional hearing officers who themselves are usually lawyers. So that's made things a little more expensive. But sometimes that's good, and sometimes the docs get bad advice from these lawyers. They'll just say, fight it, fight it, fight it. Where if the doc had just said, yeah, I did that, I'm sorry, I won't do it again, I'll do remediation, and it was done. And we've had some just fight, past the board up into the court system. And I think driven by pride, but that's unfortunate. All right, next slide, Jonathan. We sometimes get folks to withdraw applications. That's the first one. Agreed orders, reprimands. That's where we didn't have to do any kind of adjudication. The person just said, I agree, I messed up, I'll accept a reprimand. We only had one impaired provider assessment last year, and restored license. That's when someone is given back a clean license. The stipulation is removed. And then finally, hip whip. Hip whip is with your licensing money, we support a group called the New Mexico Health Professionals Wellness Program. It used to be called MTP, Monitored Treatment Program. And what they do is they monitor providers that have addictions issues. They arrange for urine testing. They arrange to be sure that you're seeing your therapist, or you're going to AA meetings or whatever, and kind of keep you on the straight and narrow while if you're in recovery from a substance use disorder or a mental disorder or whatever. Participation in hip whip, it can be voluntary, in which case you go and I've got a problem, you sign up with hip whip, board doesn't learn about it unless you get into trouble in your practice. If we find that you got into trouble, you showed up to work drunk or something like that, then hip whip, unfortunately, it is kind of known to the board, and it can be public knowledge because there'll be a stipulation on your license. But one of the cool things about hip whip, and you should invite them to come talk to you guys sometime, is we've got like a 90% success rate. And those of you like me that do addictions work know that that's incredible. After 5 years, something like 85 to 9% of the doctors are in full recovery, and they're working and they're doing great. And this probably the secret to that is, one, urine tox screens, although we're starting to do these breathalyzer things so you don't have to go into a lab. The second thing, you've got a lot to lose if you lose your medical license, and hopefully you're not an idiot. So, you do what's asked of you. So it's a really great program. All right, next slide, Jonathan. All right, we're almost done. There won't be a lot of time for questions, but very quickly, some of the challenges we're dealing now that came up during the pandemic. One is misinformation and disinformation. Docs telling people, this horse deworming medicine will treat your COVID. What do you do with that? Is that unethical? Is that freedom of speech? What do you do with that? So that has come up. Not believing in masks. Take that mask off in my office. What do we do with that? You know, is that unprofessional, dishonorable, whatever behavior? It's a free country, you know. So these are some of the things we were struggling with. You know, that ivermectin, you know, off-label prescribing. You know, I was at a meeting. There's an entity, the Federation of State Medical Boards. It's all the state medical boards. They get together, they issue policies, like they issued a policy on misinformation. And I went to their last meeting, and I was stunned at the arguments from the representatives from different states that took different sides depending on whether it was a red or blue state. And you think this is medicine, you know, we should all be kind of on the same side looking at the same clinical information. Not always the case. I was also stunned at how many of my colleagues didn't understand off-label prescribing, you know, which we do in psychiatry all the time, you know, but that was interesting. The explosion of telemedicine, you know, there are entities out there that want to treat you based on the answers you put in a checklist. Is that okay? You know, psychiatry, should we be doing mental status exams by telephone only in patients we don't know? You know, there's a lot about telemedicine that there's very little evidence that it works or it's safe, but we were thrown into it by COVID in order to keep seeing people. So these are all things that the board is thinking about. Most states have some sort of telemedicine regulations. We have a little bit, but we really don't address it. The other thing is expanded licensure. It's kind of funny. Several times the representatives of the governor's office would tell us that we should allow people to practice in New Mexico without a New Mexico license, you know, during COVID. And we had no statutory authority to do that. And we had to kind of push back a little bit. We did implement something called a federal emergency license where we could give licenses, but there was that push to lighten up, you know, our regulations, which, you know, we didn't do anything that actually conflicted with our statutes, but, you know, we tried to be as accommodating as we could. And I think there may be a last slide, Jonathan. I think this is it. Oh, so key points. The medical board operates under the guidance of fellow physicians, PAs, and the public. The public members are very helpful because sometimes we get a little too carried away protecting docs and they go, oh, wait a minute, let's come back to the center. Primary mission is protection of the public. Unethical behavior is specifically defined by statute. The board does not set standards of care. That's set by the profession, but not by the board. We don't routinely confirm competence in licensing. We rely on complaints. We have broad guardrails. And finally, we try to keep or return physicians to practice through remediation. And that's it. The last side is just some references, but that's about it.
Dr. Jenkusky,
all right, looks like a lot of you
so
hung in
much.
there.
Yeah, and there are some questions or comments in the chat, possibly.
Let's
Do
see
you have access to them, or?
Yes. Brant Hager I think many of us were on the receiving end for caring for patients of a couple of physicians whose questionable prescribing practice occurred. Yes. Yes, sir. Two psychiatrists. Robin. Oh, if you missed the QR code, okay, that's to everybody. Molly says, thank you. Thank you, Molly. And
Dr. Jenkusky, did you see Dr. Khalil's chat from 138 about the prescribing abortion meds under telehealth?
Under telehealth outside. So I think this will answer the question. You have to have a license in the state where the patient is located. So if I'm reading that right, one would have to have a license. So if you want to prescribe an abortion med to someone in Texas, you have to have a Texas license. Although Texas specifically legislated against telemedicine prescribing of abortion meds.
So if it wasn't for Texas and another state that didn't have that, they wouldn't be able to, I guess, hold you to their state's laws regarding abortions unless they specifically have a telemedicine clause. Is that fair to say? I'm
No,
just
no.
curious.
No. I'm just saying that you have to have a license for. You can do it by telemedicine. You can prescribe treat patients by telemedicine if it meets the standard of care for whatever you're treating. But you need a license for the state where the patient is located. So
That makes sense. Thank you.
if the patient's in California, you need a California license. If they drive to New Mexico and get on the phone, you can prescribe it to them. They're physically located. And this is another big issue. There are, it didn't go very far, but there was a Senator Udall who tried to get a federal medical license, would essentially allow you to practice anywhere in the country. VA is kind of like that. If VA, you can practice at any VA in the country as long as you have just one medical license in one state somewhere. So that didn't go anywhere. Right now in the legislature, we're trying to get past a compact that would allow 37 states have this, but not New Mexico, where if you have a license in one of those states and it's pretty clean, you can get a license in any of the other compact states in like 2 weeks. Just boom, you can get it. New Mexico, we're hoping it'll pass. We tried 2 years ago and it didn't pass. So we're working on that. But that's the telemedicine thing, because the other thing that's happened with telemedicine, and I know this through the health plan because we would pay the airfare. If you needed a specialist and you're on Medicaid and you had to go to Texas, we'd fly you out there, you'd have to stay in a hotel, you'd see the doctor, and you'd have to go back and forth for visits. Well, under telemedicine, we're getting so good at that you could be followed by your specialist back home, except for this little detail about needing a license in that state. What a lot of states are doing is try to change their statutes to maybe allow some flexibility. There's someone with their hand up. Looks like
Question.
David.
How about the patient's a New Mexico resident, but is like working in another state? And so was seen for a telemedicine visit while over there working, and
Right.
meds refilled. Is that
So
kinda...
Yeah, by the absolute letter of the law, that's not okay. But we turn a blind eye to that, frankly. If you've got I'll just say the board would never prosecute someone for that. If you're on vacation, now if you've moved your residence to that other state, that would be questionable. But if you're temporarily, away, I don't know how a pharmacist would handle it, though, to be honest. I don't know if you called in and you didn't have a license in that state. I don't know how.
Well, I'm also a pharmacist in this state, although I haven't been practicing as of recent, but it's okay as long as the provider's licensed and has like an NPI number and a DEA number if it's a controlled substance to fill, now their insurance, if it's a Medicaid patient, is not necessarily going to cover if you're, although like Gallup Walmart, for example, does have some agreements for Arizona Medicaid. So there, some of our border towns do have coverage where they accept the other state. So generally it's okay. Now, if it's something suspicious, then you're, Xanax from Pennsylvania or something crazy that doesn't have like a clear. But there is a stipulation in this state where if you have an out-of-state controlled substance prescription from anywhere that comes to us, that it needs to be verified because of some of the issues, predominantly with promethazine with codeine abuse being phoned in mainly from places in Texas. So pharmacists in this state will verify any controlled substance by contacting the prescriber to just kind of make sure it seems up to snuff. But
that's good. Yeah.
Outside of that, it can be, or the patient can show up in another state and have their prescription transferred within the pharmacy system, and they're good to go.
Right. Okay.
We
good.
are 5 minutes past time, so I know a lot of people have to leave, me included. And so I'd like to thank Dr. Jenkusky for a fantastically clear, compelling description of the medical board. And I think we're going to carry this with us for a long time. So thank you very much, Dr. Jenkusky.
All right. Yeah. Thanks for the opportunity.